We're going to switch now from bacteria to mycotic infections. We'll start with a common one, and that is Candida. Majority of candidal infections are Candida albicans. Remember that Candida albicans is a normal inhabitant of the GI tract and of the vaginal flora. You will see this in children many times, particularly in newborns. Remember, they are immunonaive. They will have colonization of the respiratory tract and the GI tract shortly after birth, and the skin is usually colonized within about 2 weeks. So it's a normal flora. However, you can see this a lot of times in infants manifested as what they call thrush or oral candidiasis, and the other major manifestation is the diaper rash of Candida. Remember that Candida is a yeast, and yeast like warm, dark, moist places. Well, the mouth and the diaper area are perfect for that. The thrush, again, these are going to be diagnoses that are made basically clinically. The oral thrush looks like milk curds, except you can't scrape them off. So a way to find out is just take a tongue blade and try to scrape the mouth, and it doesn't come off. That's thrush. The treatment is going to be nystatin. Diaper dermatitis occurs in the intertriginous areas. Look for a very raw red area, and they'll have little areas outside of it that they call the satellite lesions, and with time they become confluent. And it's really just going to be a clinical diagnosis, and the treatment again is going to be topical nystatin with or without hydrocortisone because it does bother them somewhat. Systemic candidal infections are usually obtained in the hospital. Usually you'll see this in patients who have catheters, so for example deep central venous lines. That's a great source to get candidal infection. Also, immunocompromised patients are at higher risk for systemic candidal infection. You don't see that very often in a regular, normal child who's healthy. So when they do have systemic candidal infection, think of other predisposing factors. The treatment is to remove the catheters if they have them and treat with amphotericin. Chronic mucocutaneous candidiasis occurs in patients that have autoimmune or endocrine problems. So look for patients with, like an example, diabetes. Here is a baby with the diaper rash of Candida. You can see it's very raw and red, and then it extends outward, and here it's somewhat confluent, and these little discrete areas are what we call the satellite lesions. This is oral Candida, the milk curd appearance. You can try and scrape that with your tongue blade, and it just doesn't come off very easily. Cryptococcus is going to be found in soil that's contaminated with bird droppings. You can sometimes find it with fruits and vegetables. That's why you need to wash them thoroughly. It is the predominant fungal infection in HIV patients. It's very rare in children. The other population that gets it, other than, for example, HIV patients, are people who are pigeon breeders, and lab personnel that work with the Cryptococcus can infect themselves. You can inhale the spores. It can disseminate to the brain, cause a meningitis. They can cause granulomas, but the most common manifestation is going to be a pneumonia. The diagnosis is made through culture. The most useful test for diagnosis is a latex agglutination test. The treatment is going to be fluconazole. Histoplasmosis, another one of the mycotic infections, Histoplasma capsulatum. Look for soil that's contaminated with bird droppings. Also, decayed wood. For the exam, look for bat droppings. So, if they talk about someone who likes to explore caves, or if they use the word spelunker, that's where the bats are, that's where the bat droppings are, that's how they can get histoplasma. Knowing your geography again, remember it's throughout the Midwest, especially in the Ohio, the Mississippi river valleys, very common in those areas. You will inhale your microconidia, and then they proliferate as yeast, and they can cause pneumonias, and they can actually look like tuberculosis. Histoplasmosis is divided, the disease, into various subsections. You can have acute pulmonary histoplasmosis. This is usually flu-like symptoms in younger children. Most patients with it are fairly asymptomatic. The chronic pulmonary form is going to be seen in adults, and then there's the progressive disseminated disease. This is going to be very common in immunocompromised patients, and that is an AIDS-defining illness. The diagnosis of histoplasmosis, sputum and blood are usually negative. In addition, children don't produce good sputum for you anyway. Seroconversion can help as far as titers, but radioimmunoassay is probably the best test to use. You can use serum or urine for radioimmunoassay. The treatment is usually with oral itraconazole. The progressive disease, you go to amphotericin B. Coccidioidomycosis, again, you have to know your geography. It's also known as San Joaquin Valley fever, so look for the Southwest. California, also Arizona, and Texas. There really isn't a person-to-person transmission of this disease, and there are several forms. The primary form is usually a mild disease. The residual form shows maybe some cavitation on chest x-ray, and the disseminated form, you need to remember, is more common in males, in Filipinos and Asians, and remember blood group B. So if they're type B, they're at higher risk to develop disseminated disease. The primary disease consists of some chest pain and maybe some coughing. They can have a rash, so remember rash and San Joaquin Valley fever, and also remember erythema nodosum, particularly tibial erythema nodosum. I'll have a picture in a second. The diagnosis is going to be made with PCR, and it's treated similarly to histoplasmosis. This is erythema nodosum. Look for it, particularly tibial erythema nodosum, all this reddish area.